So without further ado, I'd like to invite Vincent to present the diagnosis and risk stratification for plasma cell disorders, to treat or not to treat. And so please welcome Vincent.
Thanks so much, Brian, and thanks to all of you for being here. It is really, I'm really sorry that Jesus San Miguel is not here to give this lecture. He prepared the slides and I have not modified it much. We're just going to work off his slides. But before we go on to the talk, I just want to go ahead and present a case to you. This is a 51-year-old asymptomatic woman found to have an IgA kappa paraprotein, M spike 1.2 grams per deciliter, free light chain ratio, renal function, hemoglobin, everything is normal. So the first diagnosis was MGUS and the patient was followed. During follow-up, 3 years, she remained stable, at which time she consulted a myeloma expert. At that time, the M spike had increased from 1.2 to 2.3 grams per deciliter. The free light chain ratio had gone up to 25. She had Bence-Jones proteinuria 500 milligrams per 24 hours, bone marrow biopsy 28% plasma cells, of which 97% were clonal cells, and there was a 414 translocation. CT scan was negative, but the MRI showed one focal lesion. So a diagnosis of smoldering multiple myeloma was established. So the question is, let's vote now on how you would manage this patient. Would you recommend observation alone? Start therapy with lenalidomide alone, lenalidomide and dexamethasone, lenalidomide, bortezomib and dexamethasone, daratumumab, or not sure? Please vote. Okay, we have a third of you saying just watch, and then 25% are ready to treat with full-blown myeloma therapy, and everybody is in between. So this is important and this is great because this is the type of discussion we need to have. And at the end of this, I'm not sure how much this is going to change, but let's see. So this is how the experts voted. We were also like you. Two of us said Lendex, two said bortezomib Lendex, and two were very honest and said unsure.
The others are honest too.
There's one more question. This is a little bit more complicated. Let's say we know about this patient, 2.3 M spike, no crab features, one MRI focal lesion. I'm giving you another patient Dr. San Miguel has picked. The same 51-year-old, asymptomatic, 2 grams M spike. There is no 414, but instead of the 414, the patient has imaging which shows lytic lesions in the skull and one in the clavicle. Question is, who is at greater risk in terms of survival? The patient with the 414 without any lytic lesions, or the patient without the 414, case B, with lytic lesions, or you think both have similar risk, or you're unsure? This is a test of honesty here. Wow. So 40% think that the person with 414 is at higher risk of inferior survival. 34 say case B, 13. Here's how the faculty voted. So I'm going to move to the faculty. And totally unsure. And these were really taken without each of us knowing how the other is going to answer. So let me just walk you through the presentation and then we can go through these cases again. Before we start on smoldering multiple myeloma, I'll start with MGUS. MGUS, or monoclonal gammopathy of undetermined significance, as you know, is present in 4 to 5% of the general population over the age of 50. That means some of us here have MGUS. On the left-hand side, you can see that the International Myeloma Working Group in 2014, with the revised diagnostic criteria, classified MGUS into 3 types: the non-IgM, light chain, and IgM type. Each one has a different problem. You know, non-IgM tends to progress to multiple myeloma, whereas IgM tends to progress to Waldenstrom's or non-Hodgkin's lymphoma. If MGUS only caused myeloma and Waldenstrom's and amyloidosis, that itself would be a major public health problem. But MGUS is also a culprit in a number of other disorders, like light chain deposition disease, neuropathy, cryoglobulinemia, ITP, acquired von Willebrand's disease. So there's a lot of clearly M protein related disorders caused by M protein that are now recognized. For example, 50% of patients with membranoproliferative glomerulonephritis, the cause is monoclonal protein. So there's new terms like monoclonal gammopathy of renal significance and neurologic significance and clinical significance being developed. In addition, MGUS is kind of vaguely associated with a number of other medical problems where you cannot pinpoint the cause. Like, for example, patients with MGUS are at increased risk of vertebral fractures. They're at increased risk of deep vein thrombosis. They're at increased risk of infections. So MGUS is a clinical problem that most of us face, which has multifaceted problem. But overall, its main significance is that it can progress to myeloma at a rate of 1% per year. Bob Kyle has studied this, and he has updated this in 2018, and you can see 1% per year persists, and this curve has been extended now up till here to 40 years. It's always 1%, and it's there throughout. If a patient has been stable for 30 years, the next year they still have a 1% risk of having myeloma-related disorder. Smoldering multiple myeloma is a different problem than MGUS because instead of 1% per year, now you're dealing with a population that has a 10% per year risk of progression over the first 5 years, after which it slows down to 3% per year, and after 10 years, it becomes more or less like MGUS with 1% per year. So this is a different problem. It was first described by Bob Kyle in 1980 in the New England Journal of Medicine, and we have learned a lot about this disease. When Bob first described it, the concept was smoldering multiple myeloma is like an in-between stage. It is in between the benign MGUS and the full-blown malignancy of multiple myeloma. It's something that is smoldering, ready to move. Now our understanding is different. We have a paradigm shift. We think that smoldering myeloma is an artificial clinical condition comprised, let's say if you have 100 people, 50 of whom have MGUS, 50 of whom have myeloma. You just don't know who's who. And therefore, we're just calling them a smoldering myeloma. If you follow them within the first 5 years, the myelomas will declare themselves. They will progress. After 5 or 10 years have passed, what you're left behind is only MGUS, and therefore the progression rate becomes only 1% per year. This is an important paradigm shift, and it tells you why we are ready to treat some of these patients. It's not like we are dealing with an intermediate pre-malignant condition. We are dealing with a problem where half the patients in this subgroup that we call smoldering actually have myeloma. We just don't know who's who. The first step we did to rectify the problem was to take away the ultra high risk, the patients who are at 80% or higher risk of progression within 2 years. That's 40% per year. We moved them and called them as multiple myeloma in the 2014 criteria. But that still leaves behind a significant chunk of smoldering myeloma in the same smoldering myeloma bucket. We still need to know who are the people who won't progress as much and who are the people who are going to progress 50% or more like risk of progression within 2 years. This is the group that we need to identify. In the old days, this was done by the old Mayo classification, more than 3 grams, more than 10%, that's this group, or by the Spanish classification. These are the criteria that were used in the old clinical trials, including the Spanish clinical trial that looked at Lendex versus observation. But these criteria have limitations because they classify only a small number of people as high risk, and there are some patients who don't actually progress as much. So the Mayo Clinic came up with a 2-20-20 risk stratification. Basically, more than 2 grams M spike, more than 20 for the free light chain ratio, and more than 20% plasma cells. If you have 2 or 3 of those criteria, that's high-risk smoldering myeloma. And last year, actually this year at ASCO, the IMWG validated these criteria in a study of over 1,000 patients. And you can see the high-risk group, which has 2 or 3 of the high-risk factors, comprises about half of the overall group and has a risk of progression of 5.63. Now, if you know, in addition to that, if you know the cytogenetics, for example, 414, which is a known high-risk cytogenetic, that risk goes up even more to like 60% risk of progression at 2 years. You can refine this even more because not all risk factors have equal hazard ratio. So the IMWG presentation that Dr. Mateos gave at ASCO also had more detail by putting up a risk score depending on how much the free light chain ratio was abnormal, how much the M protein was high, how much the bone marrow abnormalities were, and the fish abnormalities. For example, the patient that we saw with a 2 grams M spike, 20 plus free light chain ratio, and 28% bone marrow plasma cells and 414 will have a score of 11, which will be right in between these two curves. Not quite 50% risk of progression, but more like 60% risk of progression. So this criteria allows you to more or less refine and counsel your patients more accurately because they want to know, doc, what is my risk of progression? And instead of giving them a rough guess, you can more or less precisely tell them what the odds are going to be. There are several other additional factors. For example, this is a snapshot in time. If the M spike keeps going up or if the hemoglobin is falling, evolving would be another risk factor. Circulating plasma cells, gene expression profiling, you can use this to refine this further. The question in smoldering myeloma has always been, and I'm talking since the 1960s, should we treat or not? People have tried melphalan, people have tried thalidomide, people have tried bisphosphonates, chemotherapy combinations. Generally, nothing has stood the test of time. And the main reason has been that, number one, we didn't have good biomarkers to tell who's likely to progress and who doesn't, and now we do. Number two, we have always been worried about harm. We don't want to harm people who are completely asymptomatic with therapy and the risk of clonal selection. The question is, are we there now? We are learning now that some people with smoldering are more or less myelomas who are going to get myeloma within a year or two. Should we just consider treating them early? And one of the key reasons why we have not treated these patients is the data was scant. There were hardly any clinical trials, and the clinical trials were not of good quality. Now, if you do a PubMed search or clinicaltrials.gov search, you will find that there are 50 trials going on for smoldering multiple myeloma. Trials with single agent, trials with doublets, trials with triplets, randomized controlled trials, single-arm trials, even trials like Ascent and Caesar, which are trying to cure smoldering myeloma, which are trying to cure myeloma with full-blown, not only myeloma-like therapy, even more than myeloma-like therapy. Some of these trials, we already have data. Some of them, data are coming. The two randomized trials that have been done recently are shown on this slide. This is the Spanish trial, presented first by Dr. Mariby Mateos in the New England Journal of Medicine in 2013 and then updated in 2016. What she found was that there is a 75% reduction in the risk of end organ damage. Here, the progression-free survival is not defined by M protein going up. This is actual end organ damage. You reduce that by 75% by using lenalidomide and dexamethasone. And not only that, you also improve overall survival. This trial showed this in 2013. We are in 2019, almost going into 2020, and the standard of care did not change, even though a survival benefit was shown. That tells you how much diversity of opinion there is among the experts and how we are still arguing amongst ourselves whether or not we should treat smoldering myeloma. But the trial that showed a survival benefit had one problem, which was that it used Lendex, so it was not a regulatory study. Number two, it didn't image patients adequately at baseline, so people thought maybe some of these patients had myeloma. A second trial that Sagar Lonial led for the ECOG group has now been published, which overcomes these two deficiencies. It's been published in the Journal of Clinical Oncology last month. And what we found was a very similar reduction in the risk of end organ damage. But so far, there are only 6 patients in this study who have died, 4 in observation and 2 in lenalidomide arm. So it's very difficult to tell what the effect on overall survival is going to be. This is all that we know. There are many phase 2s going on, Elo-Lendex, Ixa-Lendex, daratumumab. There's a phase 3 with daratumumab that has been completed and results are pending. The ASCENT trial is ongoing in the United States, which uses KRD-DARA, and that is led by Dr. Kumar. The CSER trial uses a very intense curative approach with induction with KRD, transplant, consolidation, and maintenance. This trial is going to be presented again this ASH, and I encourage you to go for that session and listen to that presentation. The trial is showing an MRD negative rate of about 63%, but more importantly, 94% of patients are progression-free. We don't know whether or not this will be the right thing to do. There are side effects to consider, but so far it looks like it's manageable in terms of adverse events. The real question, because of the diversity of opinion, is, and this is not my thing, but I completely agree with this. This is what Dr. San Miguel wrote. Should the doctor decide for the patients, or should the patients decide for themselves after the appropriate information, which is this is all the data we have. It's going to take years before we know overall survival. Should you decide for me, or should I think about the pros and cons and decide for myself? I'll close with Dr. San Miguel's closing slide, as he wants to acknowledge the huge number of hospitals in Salamanca, Navarra, all of Spain, which have contributed to the studies, as well as the International Myeloma Working Group, which has multiple people here you can recognize. And so I will close with this slide. Thank you very much. Should we do the case? We'll do the case and then we'll go to the panel discussion. Let's just return to the case here. This patient that I just told you with 2 grams M spike, more than 2 grams M spike, more than 20 light chain ratio, 28% plasma cells, 414, and 1 focal lesion on MRI. Let's vote on what you would do. Go ahead, start the timer. The music. Okay. It looks like most of you would now treat, unlike the first prior to the session, and so we'll sit and have a discussion on this. So it looks like the number of people who would watch the patient without therapy has dropped from 36 down to 21. Versus about really 65% would treat with either Lendex or with the triplet. So we can have a panel discussion now, and I'll ask Dr. Dury to lead the panel discussion.
So thank you so much, Vincent. Very interesting to see the difference in the voting after your presentation. A shift towards something which actually you don't personally recommend, I think. But do we have any comments from our panel members about Vincent's presentation? Do you want to give your perspective on how to manage smoldering? Tom?
We'll see. I voted unsure for 2 reasons. And one is with smoldering myeloma, and Vincent said this. Taking a snapshot and trying to make a decision at that point in time is very difficult. I think we all should get comfortable in being able to follow these people closely every 3 months for at least the first 6 months to 12 months after their diagnosis. I'm kind of a lumper in this scenario. They either have MGUS or they have active disease and should be treated like active myeloma. In this specific case, the 1 bone lesion, I always get worried about 1 bone lesion. Is it really myeloma or is it something else? And so I would go to my radiologist and I would go over all the examinations. And if it was confirmed that I think that was certainly a myelomatous lesion, then I would favor actually going on to treatment.
Right. I would have to say that my perspective is somewhat similar. You saw the picture from Vincent with the black coals of MGUS and the active flames of myeloma. I think that to the best of my ability, I try to classify patients into one of those groups, and I feel if it's more towards those active flames, that was why I selected to actually treat the patient as if they had myeloma. Any comments?
So the two things that I will tell you is that, I'm a data-driven person. It's really nice on paper to say we'll follow these patients. That assumes that you can catch the end organ damage in time. In reality, that is not going to happen. I'll tell you why. In the ECOG trial, patients in the Smoldering lenalidomide arm, as well as the patients in the observation arm, were seen every month. And we still had, in the high-risk subset, a 90% reduction in the risk of end organ damage with early therapy. Number two, we did a study in Olmsted County, which is the mecca of smoldering myeloma and MGUS, and Giada Bianchi published this in Blood years ago. Only 17% of patients with MGUS were diagnosed with myeloma by the doctor suspecting, oh, the M spike is going up, and doing a workup. Even for patients in Mayo Clinic, Olmsted County, 83% were diagnosed with a disaster, like hospitalization, end organ damage. Unless you're planning to see the patient every day, you're not going to catch that end organ damage in time. So even follow-up, unless you're willing to start therapy when the M spike goes from 1.5 to 1.6, is not going to happen. That's my worry. And the number two reason why I don't recommend myeloma-like therapy right now is we need to really find out, is a preventive approach better or a full-blown myeloma approach better, not only for deciding what's right for the patient, but also for regulatory reasons. We have a clinical trial going on in the United States. For all of you who are in the US, please enroll patients in trials. Don't listen to my algorithms. Do the trials. The trials are the best way to manage the patients. This trial is comparing Lendex, what the Spanish showed improved survival, versus daratumumab Lendex, which is what we think a good myeloma-like therapy would be. And so the trial is asking the question, and if the clonal selection or harm by doublet is there, it will be seen in that trial. Let's do the trial. The trial is open. Let's not put patients outside the trial as much as possible unless you're really forced to. But try to do the trials, and the trial is asking the right question: is a myeloma-like therapy better for high-risk smoldering than a mild therapy?
Okay. I don't see any questions, which is a bit odd. No one has any questions about any of this?
Can I add to that too? And so Vincent, I couldn't agree more with that, what you said. The one thing I'd like in a trial is that the randomization is to treatment versus the intent to treat if you think they're progressing, not observation. Because we observe them for what? We observe them for an end organ problem. But instead of just observing them, we observe them to start therapy when we think there's a change that made us do that therapy. So they can get early therapy, but that's based on what we do in real practice. Yeah. And I think that would be more informative.
And I would really love to launch such a trial. We just, I'm involved in the daratumumab alone, single-agent smoldering myeloma randomized trial. I'm involved in the ECOG trial. I've done 2 other randomized trials in smoldering myeloma, so we are trying. But there are only so many trials we can do.
Right.
So I would encourage, if you really think you can actually manage smoldering by incremental, go ahead, run the randomized trial, and let's find out. Keeping in mind that until the trial comes, the data we have right now is that if the M spike goes up by 0.5 gram and the hemoglobin drops by 0.5 gram, that patient is at 90% risk of progression within 2 years. So those patients, you should be ready to treat. If you decide you're just going to watch them, but the M spike is going up and the hemoglobin is falling, don't wait for the full crab.
Philippe?
Yeah, I think that the case that was presented by Vincent is a very difficult one because the patient was 51 and she had a translocation 414, and according to the updated risk stratification for smoldering myeloma, the new International Myeloma Working Group classification, we have these three criteria that are very important. The M spike of more than 20 grams per liter or 2 grams per deciliter, the 2-20-20 classification, 20% of plasma cells, and the free light chain ratio of more than 20, above than 20. And then the specific patient have all these three criteria, plus 414 translocation. It means that if we are going back to the slide number 29, this slide is very, very important for the decision. The risk of progression to a symptomatic myeloma at 2 years was 60%. And the patient is 51. So, okay, why not treating this specific patient? She has a very high risk of progression, but how best to treat this patient? We have overall survival data with Lendex. And based on the study from the Spanish group, from Mariví Mateos, published twice, in fact, with a very long follow-up. The median follow-up for time to progression was not reached in the Lendex arm after 70 months of follow-up. It means that potentially we are going to delay progression, but can you imagine that the patient will receive Lendex during 7, 8, 9 years? I'm not sure that you will be able to tolerate 7 years of Lendex. To my opinion, that's not feasible. Or, on the opposite, you have the curative approach aimed at curing the patient based, for example, on the CESAR study or the ASCEN study with a very intensive treatment. I would favor, in fact, very intensive treatment, but I would like to see the final results of Mariví and the study that is ongoing in the US, chaired by Shaji.
I think you bring up an important point about the limited duration of therapy, and I don't think we should just say don't treat because all the data shows patients are being treated continuously. I think looking back at Yesu's slides, I think the most important slide was the one who decides treatment. Is it you or is it the physician deciding or the patient decides? Because what we are really saying is now you have 2 trials with progression-free survival improvement, which if it was a drug or if you look at the transplant versus not transplant, with similar curves, we are willing to transplant the patient with myeloma with the same degree of PFS improvement without overall survival difference. So the question here is you have to show the data to the patient and say these are the pros and cons and partner with them to make the decision instead of saying, no, I don't believe this, I don't want you to be treated, or I believe this and you should be getting Lendex. And I think the second big question is, we don't know the answer to the question, as Vincent said. Should we be trying to prevent the progression the way the ECOG trial or the Mariví's trial was designed, or should we be treating them like myeloma? And I think that's where the clinical trials are being designed to ask the question, is it DRD better than RD? And I think the good thing about the ECOG trial is it is a limited duration of therapy and specifically gets to the question that you raised, Philippe. Can we stop therapy after some point in time?
So we're going to have to move on. The only final comment that I would make is that hopefully with molecular testing or immune testing, we will reach the point soon where we can tell if a patient has early myeloma or MGUS. And so there will be no more smoldering myeloma. So we won't need to have a lot of trials. I think that would be the simplest answer that we can achieve within the next 2, 3, 4 years, hopefully.